to debate that probably bipolars are here to stay, and what exactly would be the indications and rest of the things would be covered in this topic. So hopefully by the end of this session, we should have a clear idea on when and how to do the bipolar hip replacements, and as far as implants are concerned, what should be the choice of implants if you are doing the same.
Yeah, so at the end of the session, we intend to give clear-cut guidelines, especially so for the junior colleagues. Should we plan our bipolars? Should we do cemented or uncemented? Which approach should we use, anterior or posterior? What should be the implant design? Is cement disease a hypothetical or a real entity? How to deal with complications, how to prevent dislocation and fractures? Should we be doing bipolars in intertrochanteric fractures? And let's have a take of everyone on the Indian implants. Are they good enough?
So we are not discussing about the intricate details of the procedure or anything, but it's mainly if at all you are doing a bipolar hip replacements, what are the choices and how would you approach a particular patient and what would be the indications. So first thing that if I have to go, I would like to ask the panel, what is your indication for doing a hemiarthroplasty?
So if you want to discuss regarding this particular patient, what you have put on the screen, I would consider bipolar for a patient who's of say 65, 70 years of age, who's got, or maybe more, maybe not that many years of physiological or life which is remaining. So less than 10 years life expectancy is where I would consider a bipolar vis-a-vis a THR. Okay, now if this patient...
So we'll have a quick rapid fire. Jayesh, what is your take? What would be your indication for doing a hemiarthroplasty?
Life expectancy 8 to 10 years and highly comorbid patient.
Anything different, Nirbhay, or anything different?
Whether he is 75 years young or he's 75 years old. So what is his activity level before he fell down? That's number one. Whether he's a community ambulator or he's a proper full-fledged complete ambulator, number one. Number two, I like to look at his ASA grade as well. So anything who's ASA 3 or 4, I would probably push for bipolar without a second thought.
Okay, anything different, Kunal?
No, same thing, and life expectancy and maybe the osteoporosis of the patient to see if it is fixable or not.
Okay, so there are various literatures which are there. So we are going to go evidence-based. So whatever the panelists are saying, whether it matches up with the evidence base is what we are going to look at it. So there are various papers in that where they have said that in cases of displaced fracture neck of femur in a lucid elderly individual with life expectancy which is less than 5 to 10 years of age, you can consider doing a hemiarthroplasty. So there are various papers on that, so we will not go through the papers, but that is what it comes down to.
Okay. Now we come to the next point. When we are going to do a bipolar, should we just wield our scalpel and rush into the OR? Or do you take time out to plan your bipolars? Do we template them? So let's start with the panel. Kunal?
Usually I do not template them, frankly. So it's either I decide cemented or uncemented, and I do not template.
But then that's planning, right?
Yeah, that's planning, but I do not template. That's only planning.
Yeah. Nirbhay?
I always template, I always plan. I want to see two things. I want to see head size, which I want to be on tape, number one. I also want to try and get the leg length as near as possible, so I will definitely measure the preoperatively, the center of the head to the top of the LT to get an approximate leg length so I can match that intraoperatively.
Jayesh, do you want to look at the opposite normal hip and see the offset, the natural offset, and plan your implant accordingly?
The offsets as well as the stem size also. Because sometimes if you are planning to use an uncemented in a very, very wide canal, then you need to know that the biggest size sometimes might be smaller for them.
Yeah.
I like to do that, what he said absolutely correctly, I missed that point. I would like to do the X-ray of the opposite side because that gives me an approximate neck shaft angle. So if I'm using an uncemented stem, I can decide as to whether I want to go for a 135 or a 125 stem.
Suraj?
I don't really plan my bipolars, but I would want definitely do a pelvis with both hips view. In case there is something out of the ordinary, then I would be tempted to plan. Otherwise, straightforward, I would consider more the clinical condition of the patient. That is more important for me because
okay, to sum it up, it's not hard and fast to go and template your bipolars, but yes, you do have to do some mental planning so as not to run into problems.
So just to add to that, because you said many of the people say that you don't want to plan, but how would you manage your limb length discrepancy? Like if you want to have a proper lens, what should be the neck cut and how would you manage that then?
So more than limb length discrepancy, what I would do is that soft tissue tension whilst intraoperative is more important for me. Having said that, yes, I will counsel the patient that there could be some limb length discrepancy, but I would try to equalize it as much as possible intraop.
So point well taken. So you would go more for the soft tissue envelope and the tensioning rather than going in for a limb length, which is there. Fair enough. Now this is again another thing which is there because there have been literatures which are quite confusing about what kind of prosthesis you will be using in a bipolar hip replacement. Whether you want to use a uncemented or a cemented, and then again the different types of uncemented and the cemented prosthesis which are available. So just a take on that, when you say that I'm going to do a bipolar tomorrow, what is going on in your head? Whether uncemented or a cemented, you have any criterias of your own, or how do you decide? Do you decide on Laridor's type A, B or C, or you have different kind of criteria that you're looking at?
So primarily I would like to uncement all my patients. That's what I would prefer. And I consider it mainly for patients who are elderly, who may have some other issues, who may have a low cardiac output, which is many a time the case.
Jayesh, what's your take?
So I go by DOR's classification, and if it is DOR A, then uncemented. DOR C, I'll like to go for a cemented.
For some time now, I have definitely moved to the uncemented, as Kunal was saying. It's so much faster, so much quicker. The whole idea of the bipolar probably is to do a quick in, quick out kind of procedure. I'm pretty much happy getting a decent fixation stem with all the attendant complications of the uncemented. I will always, in a DOR C, keep a cemented stem standby.
Keeping the DOR classification in mind, I would say I will weigh the patient. How important is for me to early mobilize the patient depending on his comorbid condition. If I have to mobilize early, then it would be cemented irrespective of the DOR classification.
So if you're doing an uncemented, you don't mobilize the patient next day? Is that what you're trying to do?
Yeah, I mobilize the patient, but we have to be very careful while mobilizing in the uncemented, especially in the elderly when they are osteoporotic, especially in DOR type C, I would say.
But then wouldn't that defy the principle that you want to make the patient up and above because they're quite elderly and then you want them to mobilize as early as possible? So wouldn't that then be like do a cemented and just mobilize the patient next day rather than trying to wait and uncemented being
I said I will do cemented.
You said cemented.
Dr. Nirbhay, one point, you mentioned quick in and quick out. Yeah. So if you compare cemented versus uncemented, how much of a time difference does it make in your hands?
There are multiple papers on this as well, and the average time to do an uncemented hip is approximately 8 to 10 minutes is what I find in my hands. I might be on the slower side. It definitely takes a little longer time, even if you're doing a third generation cementing with a cement. So it takes about 17 to 20 minutes to do a cemented. So I think a quick in, quick out, especially because the patient's elderly in an ASA grade 3 or grade 4, I want to get him or her out of the OR as soon as possible. So I would stick to an uncemented hip, definitely.
Okay, so there are various papers which say that as far as the functional outcome is concerned, that whether you do cemented or an uncemented, probably the functional outcomes are quite okay. But the implant-related complications which are there, whether it is a periprosthetic fracture or other things, are much lesser with the cemented group. Even the anterior thigh pain, which is there seen in uncemented cases, is not seen in cemented cases. But as far as the function and mobility is concerned, they have seen that the cementeds do better than the uncemented. Although there are various other papers where they say there may not be a difference, or some in the other way around also, that uncemented have done well. But overall, even in a CORR 2021, it is the cementless fixation. They have said that they have done the analysis of the registry and everything, and they have realized that cementeds have probably doing better and mobility-wise and function-wise.
I'd like one take on that. When I'm doing a uncemented stem, I am perhaps more aggressive in trying to get a good fit intraoperatively to get torsional as well as rotational stability, which means the temptation to upsize the stem is pretty high, which is probably lands up with a periprosthetic fracture, intraoperative fracture. On the other hand, a cemented stem, you don't really use too much force when you're banging the hip down. So probably the risk of perioperative fracture in a cemented stem is so much lesser.
So we'll take that. So then evidence-based, what they say is that probably if you're looking at DORS classification, then type A, you would be able to do an uncemented. Cemented, of course, is always a choice. And B and C, probably they're recommending to do a cemented one as compared to the uncemented ones because they are doing better registry-wise.
Now coming to the implant design, suppose you are doing an uncemented stem. Which one should we select? Ream, tapered, proximal fit, distal fit? Let's start with Kunal.
Usually I prefer a proximal fit implant rather than a distal fit, basically because the distal fit will require more of rimming, and at that age, more the rimming, more are the chances of complication.
Nirbhay?
I think my stem design 90% of the times is one single wedge tapered implant. However, in a door type C, where I'm expecting that the proximal fit of the implant will not be great, I would not hesitate to go for a coned Wagner kind of an implant, which has got splices to give some additional rotational stability. Maybe in a door type C, I will definitely stay away from a distal fixation stem because it's likely to fracture the stem very easily.
Okay.
Same.
Same. Suraj?
HA coated uncemented is what I would prefer. Sometimes it could be that the fit is not very good, so I would not hesitate to use a distal reamer for this patient.
And if you are using a cemented stem, how would you go about selecting the stem?
So cemented stem I would use as usually as a backup is what I would. So cemented is more of a backup in my patients. I would prefer uncemented.
So uncemented is your go-to option? Yes. Okay.
So this is again another thing which is there. What approach would you like to do if you're doing it in a 85-year-old female, who's there? What would you like to do? Which approach you'll do? Do you change your approaches while doing a THR or a bipolar or in a younger patients, or the approach remains the same?
I'm a posterior guy, so I'm very happy doing my posterior hips. Having said that, I almost never use the entire Cocken-Langenbach approach. I use only the upper half of the KL approach because that's all you need to get your stem inside. The femoral part of the KL approach, you need to ream the diastema, which I don't need. I'm doing a bipolar. So my incision size is also so much smaller, which means that there is less tissue damage posteriorly. That's number one. Number two is, unless there is some scarring of some previous surgery or some kind, I would perhaps stick to my posteriors.
Posterior.
Posterior with a good capsular repair.
So just in case if someone has a cognitive function impairment, would you change your approach or you still keep the same?
I guess probably if there is something like Parkinsonism or if there's dementia or Alzheimer's, I would probably err on the side of an anterior approach because I want to definitely keep the posterior tissues intact all the time. Having said that, if it is a well-controlled dementic patient or a well-controlled Alzheimer's, I don't know if there is a term like that, I would maybe just go ahead and do what I would normally do. So
as they say, the real hip surgeons like to do it from behind, but it's a matter of training. Okay, gluteus lodge.
Yeah. So there are various papers in that. So, saying that anterior approach probably is much better in patients who are having cognitive function impairment. But as far as others are concerned, as far as you are comfortable in doing a particular approach, it does not matter. Only thing is that a good capsular repair is very important if you're doing a posterolateral approach, which is there. But in cognitive function impairment, probably anterior is the way to go.
Okay.
There is evidence that anterior approach doesn't give you a dislocation rate which is as big as posterior approach.
Yes, sir, in the cognitive function.
There is a very varied literature support for that. There are quite a lot of people say it is the same thing as both anterior posterior.
Yes, sir. So at the end of the day, it's just that both the approaches are fine, sir. But in case in those cognitive function impairment, probably it is better to go anterior because the dislocation rates are lower in those patients. As far as other individuals are concerned who are lucid, you can do any approach and the dislocation rate is the same, sir.
Sir, may I?
Do you people agree to that?
May I just answer a little bit of that? Sir, what I find that in patients who are dementic or who are Alzheimer's or who are in Parkinsonism, the easiest way to dislocate a hip is in flexion adduction, sir. Which happens when you're getting out of bed, and if you have a posterior capsular lax at that time, definitely the risk of dislocation is higher. It is more difficult to dislocate a hip anteriorly because you don't abduct the hip so much and extend the hip so much. So as flexion and adduction are the more common functions that a person uses, I'd prefer in such patients to keep the posterior capsule completely intact. Maybe that would be my way to go for that.
So my take is that even in a challenging situation, it is better off that you work to your strengths. And if you're a posterior surgeon, you work in a posterior approach only. If you're an anterior surgeon, then maybe you could do that.
Point.
Posterior capsule, when you suture it up, it is not as efficient as when you don't touch it. Is it?
Well, my personal
No, sir, please, fire.
Please go on.
so my personal thing is that your version and your placement of implants is more important than your capsular suturing. Capsular suturing gives you an added thing. Why not do it? Do a proper suturing. But having said that, I don't think a capsular suturing can compensate for a bad version.
Yeah, that's a very valid point.
Issue is posterior approach, suture capsule, is it as good as the virgin capsule?
Definitely not, sir. I don't know whether it's.
We are
something
relying
which is
on
God-given
fibrosis
can-
also. Over there, we are relying on fibrosis, that which we have put the sutures, it will fibrose.
So, do you mean to say that in a cognitive impaired person, we would like to keep a little more anti-version compared to normal?
Not more. Not more.
And
As long
additional
as it's
antiversion
stable-
will definitely dislocate the hip anteriorly. Definitely. So I would definitely not, I would stay away from excessive antiversion. What is a bit? It is extremely difficult to eyeball a bit. How would that change anything? No, I don't think so.
I would go for stability rather than something more. What is stable and what works well?
In cases which I have I must admit that I have experimented that on a couple of cases, and I found that it dislocated anteriorly in 2 of them, and I have moved back and switched back to my standard.
Fair enough. We'll just take one more question and then we'll go ahead. And probably then take the.
This is actually a comment. If there's a flexion deformity, you should definitely do an anterior approach. And to answer Dr. Tanna's question, an intact posterior capsule will always be better than a repaired one. And these elderly patients...
Because you presume that the repair capsule is going to give way.
It's going to take time to heal to return to normal strength, sir.
How long?
Some may say 6 weeks, some may say 8 weeks.
Yeah, what do you think?
No, but in the first 2-3 days, if the patient is getting out and doddering, they could dislocate. The other thing is this question of 5 degrees version is not really tenable, because if you're using the correct size of stem, it's going to be in one position. And if your head size is correct, then you're going to be secure. You've got to get your soft tissue tension right, whichever approach you use.
Point taken.
Point taken, sir. Let's move on. Bone cement implantation syndrome, BCIS, is a very dreaded issue, and it deters some surgeons from doing a cemented hemiarthroplasty. So let's have the panel discussion on that. Kunal, start.
I would say any patient with cardiac event or is at a higher risk of thromboembolism, I will go for uncemented implant, because I myself have an experience of BCI and I've seen what consequences happen. So definitely uncemented.
I've burned my fingers twice on BCIS, had a patient die post-operatively after BCIS. Having gone through that and the trauma of that, I read a lot about BCIS, and perhaps that made me switch to an uncemented stem, even for the hyper-elderly people. BCIS is definitely there. The paper from BJA, that's Journal of Anesthesia, says it's as high as 28% in stage 1, 2, and 3. Maybe of them, 2 and 3 are about 8%, which is not a low number. If you're doing 100 of hemiarthroplasties a year, that's 8 of your patients who is definitely having a clinically significant BCIS, which to me is a risk I am not really willing to take. So I'm aware about it. We have a cement curfew protocol, and I stay away from cement as and when possible.
So Jayesh, if you are planning for a cemented bipolar, and if your anesthetist says, don't do cementing in this patient, would you go with that?
So ideally we would like to plan with an uncemented, but in these patients especially are very, very osteoporotic, and at times you might not be able to get an uncemented implant in. You have to cement. In those cases, probably we would do a hand packing rather than pressurizing cement too much, as you would ideally like to do in a cemented prosthesis.
Would you use a Riles tube while?
Yes, yes.
Okay. Suraj, you're an uncemented person.
I would prefer uncemented for these particular reasons, especially with patients with low cardiac output due to whatever reason.
Choice is there is a wide medullary canal, and if the bone is not very thick, do you have any choice of doing an uncemented?
No, sir. No, definitely not.
Why are we discussing? I think by and large majority will do an uncemented.
So there are two panelists. So two panelists are saying that they do uncemented for obvious reasons, that they have burned their fingers because of BCIs. That's why we got this. And then there is a literature which suggests that yes, BCIs is seen in patients which are there, but significant morbidity or mortality is not seen. It doesn't increase the mortality rate. It remains the same whether you do uncemented or cemented. So BCIs is yes, so people will have maybe hypotension or may have heart rate which might be changing, or certain other, or hypoxia maybe to some extent, which can be managed intraoperatively also. So it's more of a fear.
I'm sorry.
Yes, sir.
Issue is, by choice, if somebody is doing a cemented, then it's a different method altogether.
Yeah.
But by choice, majority of us do a non-cemented one. So if there is no possibility of doing a non-cemented one, that's the only time we change to a cemented one. So where is the option?
So no, sir, it's not like that, sir. The uncemented ones we are talking about is patients who are able to afford the uncemented. There are so many patients who are there who are done, and by choice some people are preferring cemented also. So it's not that we are doing uncemented bipolars for all.
Sir,
That's not how it is.
Monty?
There is no cost difference between cemented and uncemented if they are doing a good cemented technique.
The same thing.
The bone plug, the centralizer, the gun, syringe, everything
Hardly
cost
any
together.
difference is there in the cost.
There is no difference between the stem part.
Sir, I think
Dr. Pachore, sir,
what
wants
he is
make a
trying to
point.
bring out, sir, is that our traditional teaching is to go for a cemented stem for all cases. Unless I am mistaken, this is what he's trying to say.
When it was there?
So once upon a time, at least, it was the
Talking about 50 years back.
not 50. I don't think.
Anyhow,
I
small
Dr. Pachore, sir.
important information for a bone cement syndrome. Everybody should take this home. Patients with a cardiac output very low, less than 30%, valvular disease, conduction defects, please do not operate them with a cement. That is number one. Number two, the central line pressure has to be there. The CVP has to be 10 and above. Most of the patients are starving and they go inside, and you give a spinal and the hypotension drops down like hell. So this is very another important message for if you are going to do a cemented, use a short stem. Do not use all pressurized technique. Just do lousy cementing, because these are the elderly patients going to survive for a year or two. So that was the information I would like to pass.
So there is one more thing.
Yeah,
Even in uncemented.
we'll take questions later because we are running short of time. Okay.
So one.
How do we differentiate between this thromboembolism due to excessive reaming in uncemented processes and the bone cement implantation disorder in a cemented? Patient is ultimately going to go into ICU, and we are just going to treat the patient that way with the physician's help. So it is very difficult to actually differentiate between BCIs. I have seen many BCIs, and somebody will say, no, I have not seen anything. So how panel is going to answer for this? Because thromboembolism may happen with uncemented also, with reaming in old age people with wide medullary cavity, open like cancellous bone, where the chances of air embolism, fat embolism is very high.
Vishy, can I answer that question of yours? So BCIS is specifically mentioned when it happens right after there is a fall in SpO2 as well as systolic blood pressure, immediately after cement insertion. So BCIS is specifically talking about what happens right after cement insertion. So I think that is what is going to separate it out from a thromboembolism of your reaming. I think compared to thromboembolism of reaming, BCIS is definitely much more, perhaps more common but less recognized.
Are there any literature suggesting that?
The British Journal of Anesthesia has absolutely beautiful papers on all of them. Donaldson as well as Olsen, both of them have got good papers on this.
Okay, let's move on. Let's talk about periprosthetic femoral fractures. So this is a very dreaded complication. Everyone has seen it. It's generally more common with uncemented implants. Suraj, your experience.
Yeah, so yes, periprosthetic fracture, especially near the calcar, is very common in uncemented, and I think there is a learning curve attached to it. If you try to upsize the implant thinking that you want a better press fit than what you have already got, is then when you would get these fractures. So there is some learning curve, and that is something which you have to get past.
So what is your take-home point? When do you say this size is correct?
Yeah, so I would go more for rotational stability, vis-a-vis, and that it is not sinking anymore, not with a very heavy hammer, with a very light mallet. And if it is not sinking anymore, that's good enough for me.
And the sound of impaction?
Sound may not change.
Okay. Okay, Jayesh?
Actually, there are papers in which they say that in an osteoporotic bone, if you prophylactically wire your calcar region while using an uncemented prosthesis, the chances of one calcar fracture and a calcar fracture propagation are far less, because for getting a good fit, you want to get in a good size, and the more once you try and upsize, the chance of fracture increases.
Okay, so we will rush through this.
One quick one. If I believe very strongly in the antivirus science, so I want to have intact bone medial to the prosthesis when I'm doing the prosthesis. If I find a prosthesis which is really close and touching the calcar, so either I've put it into varus or I have a very large size thing and the risk of a calcar fracture is higher. If there's intact bone medial to the prosthesis, usually calcar fractures should not happen.
Okay, so Parveez's paper in CORR clearly mentions that there is an increased risk of femoral fractures when you are using a cementless design. And there are several other papers which support this statement.
Have you seen any of these cases in your practice about dissociation of a bipolar?
I have not seen post-operative, but during intraoperative, I have seen a case, of course, it was an Indian implant, where I was not able to impact the head in the stem. So I had to go for a higher size.
Okay.
Not seen post-operative.
I've seen when I was scratching whatever hair I had left, so how the hell did this happen?
No experience.
Not with the implants I use.
Okay.
I reported this in the literature.
Right, sir. Right, sir. So we'll quickly go on to the other because of the less time which are there. So there are cases which have been reported. Sir has also reported one. Now you all are doing uncemented, where you're saying they're propagating that. I'm happy doing it. Have you seen any of these subsidence, and what is your take-home message on subsidence? Whether you'll be able to accept some subsidence in an uncemented hip, or how would you go about?
So subsidence is a known situation, especially in cases of uncemented, and it is expected that your subsidence will be more or less in the first 6 weeks. In fact, there is a paper by Campbell which states that up to 0.58 millimeters is accepted. Up to 58 millimeters can occur, subsidence can occur. On an average, 6 to 8 millimeters is the norm. Now, this is not in Indian patients. I imagine that Indian patients are more porotic compared to Western patients. So it is anybody's guess.
But if you put in the implant already very tight, then some amount of subsidence is not going to make a difference.
No.
But if it was not so tight to begin with, then what?
No, the subsidence usually occurs over a period of time. So soft tissues usually compensate for the tension at the joint. So joint stability usually is not affected. And 6 to 8 millimeters, even if it occurs and is a measurable difference in the limb length discrepancy, patients usually don't recognize it.
Subsidence.
Yes, if it's very large. If about 6 millimeters, it's fine, sir. No, I'm saying that I am not going to.
It's an arbitrary figure you're talking.
Yes, of course. I'm just quoting papers, sir.
Like this which is there.
Yeah.
Yes, this will dislocate, but here there is it is, I don't know.
It's around a centimeter.
It's quite a bit. It's
Around
quite a bit.
centimeters. Right.
Here the abductors are also compromised.
Correct. Exactly. So this is something which we all have to agree that, if you're doing an uncemented hip, then these chances of subsidence are there. Because in an 85-year-old, you want to be a little more conservative in hammering and putting your implant inside. And there you might compromise in getting a good fit, and then this is what you may land up with. So that is the reason why when you are unsure and you have a type B or a type C of a Laridors, then in that case probably cemented might be a better choice. Various papers for that.
Okay. Important point. Do you do bipolars in intertrochanteric fractures?
I do that.
Yeah. And if you do you do anything different? Do you wire the trochanter?
Okay. So there are two problems of doing a bipolar in intertrochanteric. How far down do you want to push the stem, number one, and how do you do the version? These are two major problems that people talk about when you're doing a coxofemoral bypass. If you don't wire up the trochanters around your broach, usually you will go wrong as far as how deep you want to sink the prosthesis in. So I have found that whenever I have wired the trochanter and all the pieces back together around the broach, it gives me exactly the right amount of depth to which I need to sink in my prosthesis. That's number one. Number two is the version. The version, I think, I eyeball depending on the position of the knee and the foot. I think that's.
But if it's so technically difficult, why not fix them?
I have found very surprisingly on those patients who I have got the hip out or the head out, when I put the corkscrew in to get the head out, the corkscrew kind of pulls out, which makes me wonder as to how my PFN is holding it in the first place. So on occasions, I've had to put in 2 corkscrews to get the hip out. And the head is extremely product. This is usually for part 4 kind of intertrocks. They do remarkably well, and they are able to walk very quickly after a cemented bipolar with a long stem.
Yeah.
So just one thing on that, because you're saying that. So first and foremost, what is your indication to do a bipolar in an intertrochanteric fracture? I'm sure you fix intertrochanteric fractures too. Primary. No, sir, primary. Primary. So what is your indication for doing it? Like
I think
osteoporosis will be the same. So you have fixed intertrochanteric fractures also, which are osteoporotic.
So I look at the geometry of the fracture per se. And so if you have a fracture line which is going from a long beak inferiorly and a shortish neck or a subcapital kind of a basicervical kind of a fracture in the in one of the fragments is a basicervical fracture. A really terribly osteoporotic patient which I want to mobilize early because of anesthetic issues, and I definitely want them to walk quickly, I would not hesitate to do a
so Jayesh, if it were an 85-year-old patient, frail patient,
yes, I would not worry about that. I would definitely go ahead and do a bipolar.
which you would fix in a younger patient. So that's the message you want to give.
Yes, probably. So.
And the trauma surgery, when we talk about, newer thing which have come out with the positive reduction and the lateral support, probably the incidence of my doing a bipolar is reducing.
Absolutely.
Because I think quite a lot of them, they do very well for a lifetime, then the bipolar, it's going to be a short time duration. And the problems of a bipolar into the occasional surgeon are quite a lot.
So absolutely point well taken, sir, because even the literature says the same, because we are going, when you say that you can do arthroplasty for intertrochanteric fractures and then people try to do it, if they are not, to be very frank, if they are not regular arthroplasty surgeons who are doing it, if you have a long lesser trochanter fragment or a greater trochanter which is flying away and you're trying to do that, you don't know anything about versions, you don't know how much it is, even if the lesser trochanter is going down, the stability of implant is at stake, then you try to put in a distal fitting stems and then it becomes a mess. So rather than that, even the literature says that probably it's simple to fix intertrochanteric fracture which you've been fixing it otherwise. Unless or until you, and like sir already said, if there is a lateral stabilizing plate, along with that in case if there's a vertical fracture, then probably they might do better.
Two things I have done of recently, the small modification into the arthroplasty. I take an LT and put it back there, so the whole version problem is totally solved.
Right, sir.
And the GT, only tension band, we have seen so many times the GT really flying up. So I put in, if there is a comminuted GT, then I put in a hook plate. And I feel the hook plate and with or without the tension band is the one which assures the GT properly there. And these two modifications to me, it helps out quite a lot to really get a better results of arthroplasty.
Fine. Thank you, sir. Thank you so much.
So Austin Moore replacement has been around since 1940s. Does it have a role in today's day and age? Suraj?
Well, to be very frank, I haven't done a fixed or Austin Moore type of replacement. So I would, and I don't know what would be the indication for doing an Austin Moore compared to a bipolar. Meaning,
Is there a difference between a unipolar and bipolar result?
Yes, sir. It gives.
I'm talking about an Austin Moore which is cemented.
Yes, sir.
Not
So
penetrated cemented.
the results.
You mean a Thompson,
Yes.
sir?
So results may not be different, but what gives me comfort in a bipolar is the modularity for soft tissue tension.
Even in Austin Moore, he has found out the modularity. Dr. Sanjay, he has really modified the implant which has got a modularity.
Right. Good.
And also people say that a bipolar functions as a bipolar in the beginning.
Later on becomes unipolar.
Yes.
Internal unipolar.
Correct.
Yes, so I would, as sir has pointed out, I would consider bipolar for the modularity, not so much otherwise.
Right, point well taken, sir. And it's right, actually the unipolars and bipolars, they do the same. Typically the cemented Thompsons, which we used to do it earlier and which was so cheap. So probably this might be very good for government institutes where probably finance is an issue or money is an issue.
Cemented Thompson is a
Different,
type.
yeah.
While the non-fenestrated Austin Moore
Right, sir.
is the one which is probably a better implant.
And as Dr. Ranawat says, modularity is addictive, and that is probably the reason why we select bipolars.
Okay, just to take on, do you think that dual mobility hips have any role in displaced fracture neck femur in elderly?
I would rather go for a total hip replacement than a bipolar.
No, I'm talking about displaced. So no, I'm talking about dual mobility hips in fracture neck femur displaced in an elderly individual. So rather than going for hemiarthroplasty, would you be happy doing a dual mobility hip just for the stability, or you think it doesn't make a difference?
No, it doesn't make a difference for me.
I would be tempted to use a dual mobility in a person with Parkinsonism or dementia, perhaps because it'll give me a little more additional advantage as far as prevention of dislocation is concerned. But my worry is exactly what Sir said a little while ago, that a bipolar works as a unipolar after some time. It makes me wonder as to whether this will not happen with the dual mobility. It just makes me wonder. I am not yet aware of.
Will that justify the huge cost difference? You have to
dual mobility cups do have a role in schizophrenics. The fracture neck femur with schizophrenia, when they post-operatively don't cooperate, we have seen a major difference because of no dislocation in schizophrenics also. Quite 3 or 4 patients schizophrenics do have.
Okay. Bipolar in the acetabulum and a bipolar about the dual mobility means the acetabulum is fixed. So the whole dual mobility is moving inside the fixed acetabulum.
Right.
I think these are two different entities.
Right.
So I think it has been shown that dual mobility, the whole thing completely, it has been retained, the mobility is retained rather than those bipolar which is in the raw acetabulum.
Right. Point well
Do you
taken.
agree to that?
No, sir.
I'm talking about the literature.
No, sir. So the literature-wise, as far as vis-a-vis comparing to a hemiarthroplasty, there is no difference in dislocation rates. So the dislocation rates are same whether you do a dual mobility or a hemiarthroplasty. So that doesn't get any advantage. When you're doing a total hip replacement, then in those cases, definitely it makes a huge difference, which is there, sir.
Dual mobility, if done correctly, is more stable than a bipolar hemi or an ordinary hemiarthroplasty, and it actually remains functioning at two surfaces, especially at the edges. And because of the large head, the jump distance is much more and the stability is much better. Today, younger or older patient, do a dual mobility. Don't look at the cost. Do a dual mobility. It will last you better. And there is today no place for an ordinary bipolar. You should be doing dual mobility.
So there is a meta-analysis which is there. This is thought process, but meta-analysis in 2021 has come for this, and there is no difference in the rate between.
Properly done one. In meta-analysis, there are some very badly done.
Well, I don't have a control on that, sir.
About the dual mobility,
Right, sir.
it is always available as a total hip, no?
Yes, sir.
It is not available like a bipolar.
No, sir, no, sir. It's a total hip with a dual mobility, sir.
So it is a total hip dual mobility.
Yes, sir. Yes, yes, sir.
Okay, so the take-home messages, and this is all backed up by literature. First, bipolars should be planned properly. We have to look at the X-ray properly. You have to select the implant. You have to decide whether you have to do a cemented or an uncemented. When you are doing an uncemented bipolar, always keep a cemented backup.
So it's a good choice of implant for fracture neck femur in elderly individual with 5 to 10 years of survivalship. But if the age is 65 to 70, then probably total hip replacement is the way to go. Undisplaced fractures in younger individuals definitely have to be fixed. Intertrochanteric fractures have to be fixed as per the literature which is there. Unipolars and bipolars have similar outcomes, especially it is important in cases of government-run hospitals probably where you may want to reduce the cost. But yes, modularity may not be there.
There is no evidence to suggest increased morbidity or mortality associated with cemented prosthesis, so we should not shy away from doing a cemented bipolar. Cemented prosthesis will give better fixation, immediate mobilization, and most importantly, less post-op pain, especially so in the osteoporotic bones.
Thank you. In case if there are any questions for the panelists and all, you can please ask them.
At the moment, your title as good as a natural one doing a good bipolar hemiarthroplasty. Do you agree to that title? That hemiarthroplasty is as good as natural?
No, sir. No.
So the title is
The
not
title is
Okay, final word of summation from our chairperson.
He wants to ask.
Yeah, okay.
Hi, yeah, there was a lot of discussion about cemented versus uncemented. I have myself done a lot of literature review on this, and I just wanted to